Good morning, everybody from Malaysia, and good evening to wherever you are, or maybe some of you are at your night time, right? So welcome to this Hot Topics and Research Ethics webinar series. This is a webinar series sponsored by Morris, Master of Health Research Ethics Studies, a collaboration of the Muslim Layer and the John Hopkins Berman Institute of Bioethics. I am Julia Petrengkasan, and I am from Muslim Layer, and I will start off the session now. And we also have our counterpart from John Hopkins, Jeremy and Joe here, as well as our invited speaker. Right. So we have a compilation of recorded previous Hot Topic Research Ethics webinar series. In this link, we will share with you the link in the chat box after this. Let me first introduce you to the Master of Health Research Ethics. Yeah, this is a master programs located in Muslim Layer. This is the picture of our first cohort. At this point of time, we have completed 4 cohorts, and the 5th cohort is currently ongoing. The Master of Health Research Ethics is a 1-year full-time program. It is located in Muslim Layer. The application deadline is every July or August, and the session intake starts every September or October. More aims to produce graduate equipped with the knowledge and skills necessary to engage in the field of health research ethics, which is very important nowadays with the fast-changing research landscape in the field of health. This Master More is developed in collaboration between the Faculty of Medicine Muslim Layer and the Berman Institute of Bioethics, Johns Hopkins University. It is supported by the US NIH Fogarty International Center. We do offer scholarships for selected applicants from low and middle income Southeast Asian countries. And now, over to Jeremy to introduce our invited speaker.
Great. Thanks, Julia. And thanks, everyone, for joining. I'm Jeremy Sugarman. I'm the co-principal investigator on the project with Professor Adiba Kamarulzaman from University of Malaya. It's a real pleasure today to have one of our colleagues and friends, Professor Kadija Ferryman. She's also with us at the Berman Institute of Bioethics, and we are so glad she's with us now. And she arrived at Hopkins well before the world became interested in digital technologies, and she was interested in these things before anyone else, and is just a great person to bring us up to speed on some of the related ethical issues. Professor Ferryman's a core faculty member, as I mentioned, in the Johns Hopkins Berman Institute of Bioethics. She's an assistant professor in the Department of Health Policy and Management at our School of Public Health. She is a member of the Institutional Review Board for the All of Us research program. For those of you in the US, you may have heard about this nationwide endeavor, but also a very interesting approach to collecting population-level data from folks of all walks of life. She's a non-resident fellow of the Urban Institute. She's a member of Merck KGAA's Digital Ethics Advisory Panel and an affiliate at the Center for Critical Race and Digital Studies. She's got a broad set of interests that center on the social, cultural, and ethical implications of health information technologies. And it's always great to hear her talk. And so I always learn something each time she weighs in on one of these great issues. Before I hand it over to her, though, next slide. We'd like you to do, we're going to save some time for questions and answers at the end. So please, so we can organize that discussion. We have people from all over the world joining, which is great. If you put those things into the Q&A or the chat box, Q&A is the easiest because we can sometimes take care of some of those offline during the event. Julia and I will try to moderate that at the end. The session is being recorded, and so that you can watch this as well as the others in our series. There's no service fee to look at them, unlike many of your streaming providers. There's a lot of rich content there, totally available for free. The next final slide. At the end of this webinar, there will be an exit survey that's going to open immediately following it. You don't have to do it, but we'd love for you to do it because we're just at the process of coming up with ideas for our Hot Topics webinar, which is 4 per year for this coming year. So we would love your input on speakers and some feedback on this one. And to help us improve this, you can answer that survey. That would be great. Now, let me be quiet and hand it over to Professor Ferryman. Thanks so much.
Great. Thank you so much, Professor Sugarman, for that introduction. I'm just going to bring up my slides here. Okay. Let me know. Can you all see my slides?
Yeah, looks great.
All right, awesome. So thanks, everyone. So happy to be here with all of you again. Good morning or good evening or good afternoon, depending on where you're joining from. So today I'd like to spend our time talking about the intersection of ethics and healthcare AI specifically. These were mentioned, my disclosure, so I won't go over these again. And to start our time today, I'd actually like to start off with a story. So imagine that you are a physician. You work in a community hospital and your patients are mostly impoverished and do not have health insurance coverage. A significant portion of your patient population also belongs to historically or currently marginalized groups, such as racial or ethnic minorities, religious minorities, or sexual or gender minoritized groups. You stay abreast of the latest research on medical technologies because you believe in providing the best and most state-of-the-art care for your patients, even if they are from socially marginalized groups. You've read a few articles about artificial intelligence and how it can be used in healthcare, and you become interested in learning how it can help you and your patients. You read that it is possible to use AI to predict a number of disease risks, including when someone will develop diabetes. Many of your patients suffer with this terrible condition, and it is often diagnosed later than it should be, and when complications from the disease have already started to emerge. You learn that in order for an AI to predict who's at risk for diabetes, the AI system has to learn from being exposed to numerous examples of patients who do develop diabetes. The AI can then learn patterns in patient data. Unfortunately, or maybe fortunately, your community hospital has a lot of data on patients with diabetes. And if you could train an AI system with this data, you bet it could help you identify who would develop diabetes faster than you could by just looking at their records. But you wonder how to get the data for this AI. Would your patients be okay with using their data to train an AI system? How will you know if the AI system works well for all of your patients? What if you find out that the AI system is really good at predicting diabetes risk for men, but not as good for predicting diabetes risk for women? Should you do a small-scale experiment to test the tool on patients before trying it on your entire patient population? You think about taking these questions to your hospital's ethics board, but you know that they wouldn't be able to help since you mentioned AI at a recent lunch event, and one of the ethics board members seemed unsure about what you were talking about. You become disheartened because there's too much for you to think about. You figure your patients will just have to wait for AI treatment in the future, whenever that might be, and focus on what you can address right now. So this is a fictional story, but it's a story that I hope will lay out some of the ethical questions in that I see animating AI in healthcare today. It also identifies some of the stakeholders in AI today and some of the challenges with addressing some of the ethical issues, even when they are identified. So before we go forward, just a little bit of level setting. When I say artificial intelligence, what is artificial intelligence? What do I mean by that? Or you may have also heard machine learning. What is machine learning? What is artificial intelligence? So just to level set with some definitions, according to the International Electronic and I always forget it's the engineering, what IE stands for, but it's Association of Engineers. Artificial intelligence involves computational technologies that are inspired by, but typically operate differently from the way people and other biological organisms sense, learn, reason, and take action. And so this is important because even though intelligence is in the term, AI tools are not intelligent in the same way that people or other organisms are. And then a related term, machine learning, is the study of computer algorithms that improve automatically through experience. And applications range from data mining programs that discover general rules in large data sets to information filtering systems that automatically learn users' interests. So you may be familiar with Netflix, the streaming service. Netflix is an example of a machine learning algorithm that learns what your interests are and can recommend, it can detect patterns and then recommend what you like based on the input that it gets, right? So I think about artificial intelligence as this wider, a sort of larger umbrella of various computational technologies. And then machine learning is a subset of artificial intelligence that is really focused on learning from data that it's exposed to and sort of updating its programming, if you will, once exposed to more data. Okay, so those are the basic definitions that I'd like you to keep in mind as we go through the material today. Okay. Then, so what is healthcare AI? So that is AI in general. What's healthcare AI? Well, in the past few years, there's been quite a bit of popular press and scholarly attention to the application of AI. As I mentioned, the familiar applications of AI and things like Netflix algorithms or other advertising algorithms, there's been a lot of attention on how we can use these same computational techniques in the healthcare space. So a number of years ago, Eric Topol, a well-known physician in the US, wrote this book, Deep Medicine, talking about some of the promises of using AI. Then we have a book here, The Doctor and the Algorithm, that came out more recently that actually is more of a balanced view than Topol's book, that it does include information about the promises, the opportunities, and some of the perils of using healthcare AI. And then this was a book that came out recently, sort of directed at leaders, health administration leaders, to help them think about how to begin to integrate AI in its systems. So healthcare AI has really moved into the popular imagination. So let's do a little bit of a deeper dive on what healthcare AI is. So this chart comes from an article detailing the ethics of healthcare AI. And although it's a little bit of a busy figure, I do like it because it shows a bit of the complexity of healthcare AI, right? So on the left, we can see the various sources, and these sources are sources of data that are used to train healthcare AI. And going back to the Netflix example, where I mentioned that if we think about AI that way, the data that those algorithms use are the data that you input, the movies that you select, right? But when we're thinking about healthcare in the AI space, there are many different data inputs that can be used for healthcare AI. So there's publicly generated data, person-generated data, transaction data, omic data, such as genomic data, and also medical data. And what I want to point out about the sources, and these again are sources for health AI data, not all of these data sources are what you might typically think of as health data. So for example, there's law enforcement data, there's property ownership data. We see some more familiar kinds of health data like insurance claims data and electronic medical records, but also note too that the use of online health services, that kind of data using consumer devices like activity trackers, social media data is also a source of data that can be used to train healthcare AI. So for example, researchers have shown that using Facebook data, for example, that can be a good source of data to predict the onset of some mental health conditions, for example. So the data sources for health AI are varied and not just the traditional healthcare data, or what we might think of as traditional health data. And then moving over to the center of this diagram, thinking about sort of the applications, what to do with this data. Well, there's several ways to build AI tools using this data. You can build tools that can stratify patient populations in terms of their risk for disease. Health AI tools can be built to offer decision support for clinicians. It can be used for trial design. It can be used for insurance, health insurance companies, for them to sort of figure out different categories of people to be in their insurance plans. And also health AI can have administrative functions like error reduction, cost efficiency. So in the healthcare system, things like appointment scheduling and making that more efficient. That's another administrative function that can be used for healthcare AI. And over here, we see on the far right-hand side of the diagram, we see all of the different application domains for healthcare AI, right? So health AI is not just in the hospital setting. It can be used for clinical care, yes, but also for population health, for discovery research, and also for operations research. And here on the bottom are some of the examples of the kinds of analytics that can be used. And what's also interesting too here is that you'll see there's other sort of stakeholders that are in between the sources of the data, the applications, the domains in which they're applied, and the kinds of analytics like device companies, payers, which also means health insurance companies, pharmaceutical companies, and consumer goods companies, for example. So again, we see that within the health AI space, we see some non-traditional health stakeholders like consumer goods companies and companies that are here. They're listed as data brokers. What this means is that these are companies who sort of collect data, maybe clean it up and then resell it. There are some data brokerage companies that buy data from healthcare organizations, clean it up, and then sell it back to other healthcare organizations, or even back to the same healthcare organization. So there are many different stakeholders, and as I said again, some stakeholders that are not the traditional healthcare stakeholders. So that's the sort of domain. So that was a very complicated diagram, but I want to share with you how I think of health AI in sort of a more condensed fashion, right? That health AI is really data plus statistical analysis plus healthcare systems and governance systems, right? So, and that is something, the governance system is something that was left off the previous diagram, although I do like that diagram because it shows the complexity of the healthcare space and some of those new stakeholders, as I mentioned, but they don't mention sort of who is governing the data, who's governing the applications, who are the governing bodies in the different domains where it's health AI is being applied. And so for my diagram, even though it's simpler, I did want to add in governance systems because I will be talking about the governance of health AI a little bit later in the talk as well. So how is AI used in healthcare? So I went over a few of those in the previous slide, but this is just another nice diagram, I think, that shows all of the different ways that, or many different ways that health AI is, or AI is used in healthcare, excuse me. So there's robotic assisted surgery, AI assisted medical diagnoses, drug discovery, risk prediction, fraud protection. That's some of the health insurance provider applications, as I mentioned. Also automated workflow, that's some of the efficiencies that were mentioned on the previous slide, medical data security, and clinical trials. So I wanted to share an example of healthcare AI, right? So keeping that set of stakeholders and data sources and analytics in mind, and adding the governance piece, let's get specific and talk about a specific example. So this is a very recently, I was looking up sort of like what are the recent big name or what are the recent health AIs that are making news, so I can have something current for the presentation today. And I saw that this AI device called Rapid AI very recently received FDA clearance for subdural hematoma alert. And the FDA stands for the Food and Drug Administration in the United States, and the Food and Drug Administration, which I'll talk about more later, is the federal agency in the US that is responsible for regulating medical devices and drugs. And because AI, health AI, can act as a medical device, the FDA has been approving healthcare AI tools for use in clinical settings. So this Rapid AI is sort of one of the latest. And this was an additional clearance. So initially, the Rapid AI was approved for stroke, but now can also detect subdural hematomas. And what's really interesting about this particular AI, Rapid AI, is that it has a positive predictive value of 99% for suspected acute and chronic subdural hematomas. So really very, very accurate, right? This tool works very, very well for detecting this particular condition. And so this is just one module that this AI includes. And the why this is so important is that not only is it very accurate, but the development of this tool comes after research has shown that there is going to be an increase, an 80% increase in subdural hematoma cases in the US by 2040. And there's also high mortality rates and shortages in the neurosurgical workforce. So this AI tool is sort of addressing multiple issues in the clinical space. So not only is it very, very accurate, you may say, more accurate than the average human physician, right? And maybe diagnosing or identifying this particular condition, but also this particular condition has a very high mortality rate. So it's critical for to have a tool in this space that can be so accurate, and that over the, in 20 years or so, this particular condition, there's going to be an increase, a high increase in this condition in the population. And there's also the workforce issue where there are not enough specialists, neurosurgeons, who would be the specialists who would be, diagnosing and treating this particular condition. So the AI is also intervening on a workforce issue. So this is something that is, very exciting, very promising, right? And there are a number of, and this is just the latest, and the FDA has already approved hundreds, I don't have the exact number, but hundreds of AI tools. And for some of these tools, their accuracy rates are, quite high, and the opportunities for how they can improve medical care are quite exciting. However, when AI in general, so going back to not healthcare AI, but AI in general, for a number of years, scholars have been raising the alarm about some of the dangers of AI in general. So Kathy O'Neill, a mathematician, wrote this book, The Weapons of Math Destruction. I believe it came out in 2016 or 2015, where she saw the rapid increase of AI tools in the financial sector being used in other sectors like criminal justice, for example, and raised alarm about the lack of transparency in some of these tools, how the data was being used, and who AI tools were being used on, and disproportionate harms that she saw in the use of AI in general. And then fast forward to a couple of weeks ago, actually a couple of months ago, over 5 years after this book came out, there was this very public statement, this open letter to the public written by a number of kind of public figures on AI and technology. Bill Gates signed this letter, Elon Musk signed this letter, the CEOs of OpenAI, the company that's the sort of major company in large language models, ChatGPT, wrote this public letter stating that, you know, there are risks of AI and we as a society should be mindful of them, right? Even though scholars like Kathy O'Neill and others had been writing about this, you know, years ago and sort of warning society. And recently, after this statement, you know, when the statement came out, Rolling Stone, a magazine in the US, wrote an article about women of color who also have been years before this statement was signed, who also have been doing research about some of the dangers of AI, but their work, you know, didn't get as much attention, if you will, in the public from this as this public letter from these technology giants. So, you know, it's important to, so some of the limitations that were noted in the Weapons of Math Destruction book and by the letter writers themselves, as well as some of the scholars noted before, we see some similar patterns, the alarms that they raised about healthcare, about AI in general. We see some of those same concerns in healthcare AI. So, for example, one of the alarms that was raised in a book, Algorithms of Oppression by Sophia Noble, that book came out in 2018. One of the things she wrote about was that AI search, Google search, was biased against people of color because if you type in certain terms in Google search, their, you know, racist results would be the first results that you would get. So she mentioned, for example, that if you put in Black girls, you would get sort of horrible images, and if you put in white girls, you would get, you know, pictures of you know, children, young children, for example, right? So and her argument was that, well, part of why this the search results were biased was because of the data that was used to train the algorithm, right? And so this issue of the AIs are trained on data, it learns the patterns in that data and then reproduces them in the models that it reproduces those patterns in the models. And I want to share a couple of examples of, even though healthcare AI is a relatively new field, we see some of those same patterns. So this is a headline from an article that came out in 2019, I believe, examining the way that AI had been used, was being developed in for dermatology. So using training an AI tool on images of skin and skin pathologies to try to predict, right? Predict cancer or some other skin cancer or other kinds of dermatologic diseases. But because the AI was trained on images of mostly light skin, when that AI was shown images of skin cancer on someone with dark skin, its accuracy was not very high. So, for example, a tool like this would say, oh, we have great accuracy, that's sort of overall, but then when you broke down the accuracy by different demographic groups, there were often gaps. And this, the reason why is because of the data that was used to train this model. Also in 2019, this article, this highly publicized article in the scholarly literature, so not necessarily in the public, you know, in the sort of public imagination, but in the scholarly literature, this article by Ziad Obermeyer and colleagues got a lot of attention because this was really, this article examined the use of AI by health insurers. So if you remember that slide that I showed earlier that showed all of the different stakeholders and all of the different applications, one application, as I mentioned, is the use of AI by health insurers to predict risk of their patients, to predict fraud, things like that. So in this particular case, a health insurance company in the US wanted to predict who was going to get sick in the near future, who was going to get more sick, because the sicker a person gets, the more healthcare dollars they use, and the more expensive they are to the health insurance company. So the health insurance company thought, well, if we can predict, if we can get a tool that can tell us who's going to get really sick in the future, we can intercept them from using costly healthcare services. We can connect them with care managers. We can send them care resources. We can make sure they get to the doctor, right? And this will end up saving us money, and maybe also, helping improve the health of the people on our healthcare plan. And so when they were building this AI and gathering the data to train the model, one of the main variables that they used was healthcare expenditure, because the rationale was, if we know how much money is already being spent on someone in the healthcare system, if a lot of money is being spent on them, they're probably a sick person, right? And sicker people tend to just keep getting sicker in the future. So we're going to use healthcare expenditure as one of our really important predictive variables that will, help us predict who is going to need care and who is going to get sicker and who should be getting these resources that we want to send their way. But when this algorithm was used and developed and then evaluated by this team at UC Berkeley, what they found was that instead of sending healthcare resources to people who needed them the most, the sickest people, what they found was that the algorithm was predicting that healthier white populations, healthier white patients, were the ones prioritized for these healthcare resources, and sicker Black people were being deprioritized by this algorithm. And they were sort of puzzled by this result, like, why is the algorithm doing this? And the reason why is because healthcare expenditure, that variable that they used in the data to help them predict who would get sicker, is not evenly distributed by race. In other words, healthcare expenditure is a measure of how your access to healthcare, and in the United States, access to healthcare is racially mediated. In other words, white people overall have more and better access to healthcare, which means that overall there's more healthcare expenditure on them, right? It's not necessarily an indicator of how sick you are. It's actually an indicator of your access to healthcare, which is racially mediated. So there was this racial bias, again, unintended, but racially biased nonetheless. And then another example that I'll share of sort of some limitations of healthcare AI. This was a couple of years ago. DeepMind and Google, they partnered with the National Health Service in the UK. And they were really excited to partner with them. The National Health Service, unlike in the United States, where we don't have a national healthcare system, the National Health Service in the UK, it is a national healthcare service. So the population is covered by this, which means that the health data about the population in the UK through the National Health Service is really, really good. It's not fragmented like it is in the United States because we don't have a nationalized healthcare system. So Google partnered with the NHS to say, if you can give us access to your data, we can help build predictive AI tools that can help predict who is going to get kidney disease, for example. And the NHS said, great, this sounds great. And they shared over 1 million patients' data with Google. And this got out and created a controversy, right? Because people felt like this was a privacy issue for Google, a big company like this, to get access to patients' healthcare data. So there are, and so these are just some examples of, so we have the early example that I shared of Rapid AI, that tool that is really, really good at detecting, hematomas in the brain and strokes, and is really good and can help fill in gaps. Opportunity. And then we have a few other cases. We have some other cases of where there are limitations and challenges with healthcare AI. So I want us to keep both of those in mind, some of the promises and the opportunities, and some of the challenges as well. And then in particular, because of the title of the talk, I want us to focus on, the limitations specifically in terms of the ethical issues. And some of the cases, like the ones that I mentioned, they raise ethical questions as well. And so there is a need, I argue that there is a need for ethics for healthcare AI specifically, right? And part of why we can sort of think about why we need ethics for healthcare AI, like why is it that we even have these problems? Why did Google and DeepMind not know that it was maybe not the best idea to get millions of healthcare records from the National Health Service? One theory, which I think makes sense, comes from Melissa McCradden and colleagues in Canada, which is that, and they call this the AI chasm, which is that there's a difference in culture between clinical science and computer science, so that in the way that computer scientists think about ethical issues or think about what even is an ethical issue is very different than the way that clinicians and other healthcare providers think about what might be ethical issues. And so this chasm between these sort of really different cultures around patients' approaches to patient data inform some of these problems that we see emerging with healthcare AI. So for example, one issue or one problem that McCradden and colleagues point out is that for clinicians, there's sort of a culture around data that patient data is important, but the culture is to use as minimal patient data as possible to achieve an outcome. Whereas in computer science, the culture and the sort of tradition is let's start and get as much data as possible so that we can try to sort of understand something or understand a phenomenon. So just very different approaches to even how much data is appropriate to be collected. That is part of the fueling some of these ethical issues that we see emerging in healthcare data, in healthcare AI. Okay, so how can we begin to address address these ethical issues in healthcare AI? What does an ethics for healthcare AI look like? Well, we can think about health AI ethics using bioethics principles, right? So we have our principles, respect for persons, and respect for persons could be useful in health AI ethics to help us address privacy and consent issues in health AI research. So for example, in the Google and DeepMind case that I just mentioned before, right, if there was an emphasis on respect for persons and consent, right, that maybe that what happened there, maybe wouldn't have happened. Then if we think about non-maleficence and beneficence, right, we can think about this principle in helping to facilitate that AI in healthcare development is really used for improvement of patient care and outcomes, right, for benefits and not for harm. And then the principle of justice that is central to bioethics may help ensure that certain groups are not disproportionately burdened by health AI research and or are included in beneficial healthcare AI research and practice, right? So justice can help with that inclusion, making sure that the healthcare AI development and use is benefiting equally, benefiting populations equally and not harming populations disproportionately. And some colleagues in Europe recently published a commentary in the American Journal of Bioethics, saying that there really needs to be a systematic approach to oversight of machine learning and machine learning clinical translation. So meaning sort of the implementation of healthcare AI in clinical spaces, that we really need to sort of figure out how to govern this, right? And so if we think about our health AI ethics and health AI ethics using bioethics principles, and that there is a need for some sort of governance for these tools as they're being used clinically, you might think, well, you might think that, well, we can, you might think that maybe IRBs are, what are a tool that we can use for governance. So just to drill down on a couple of, to drill down on a few other ethics issues. If we think about consent and health data, and remember, health data is a source that's used to train AI, how can we think about, consent could be useful, but maybe is it really applicable? Where are some of the limitations in just applying bioethics principles to some of the issues we see in healthcare AI? Well, when we think about health, the multiple kinds of health data, again, and from that earlier slide, we see that some of these data sources, they're not subject to the kind of consent that we would typically use or think about in a bioethics framework, right? Because as I said, some of these data sources are not traditional health data sources. There are terms of service, for example, for search engine data, but is that really sufficient for consent as we might think of in bioethics? Additional issues with using consent as a concept in healthcare AI is that depending on the kind of data that's being used to train a healthcare AI, it may be hard to get consent if that data is distant both in terms of time, like when it was collected, let's say it was collected 20 years ago, or even from the site of collection. So meaning that the users of the users of the data might be in a different, like, geographic location, for example, than the original donors of the data. So, again, the example of the Google DeepMind and the NHS. There are a few other examples of Google where and health AI where consent, was maybe limited. So, for example, a few years ago, also, Google made another deal with a group of hospitals to try to build a search bar for electronic health records. So the clinicians out there might know it's the electronic health record platform. It's not the easiest to find something quickly. So Google had this great idea to put, just like there's a Google search bar, to put that kind of search bar right on top of electronic health records on any system. But in order to do that, to train the AI, it needed data from electronic health record systems, and a healthcare organization that represented a number of different healthcare institutions shared this data with Google. A whistleblower who was working on the project told the press about it because they said, I don't know if the 3 million people who are, who are getting their care at these healthcare organizations would like Google to have access to their full medical records. And what Google said was, well, we don't need to get consent from participants to use their health data in this way because we didn't run afoul of any legal limitations or laws around healthcare data. So again, in this example, consent, as we might think about it in bioethics, was not is maybe not the most applicable here. And so again, thinking about IRBs and could they be a governance structure to help think about the ethical issues that are within healthcare AI and to help govern some of these tools. Some things that again, where there isn't a complete overlap is institutional review boards, IRBs, focus on human subjects. But recently, scholars have talked about this notion of the data subject, which is somewhat different than a human subject, right? Because if there are, the data subject is this idea that there could be individuals who have their data. A company could get data about an individual, let's say their some de-identified health data, plus their de-identified social media data, plus data from their supermarket cards or from their health insurance. And so even though it's all de-identified data, it's still data about an individual from multiple domains and arenas. And so there's this idea, well, does a data subject have rights? And what are those rights? And are they different from rights that we think of a human subject having in research? The common rule, which is also the rule that governs human subjects research in the US, it's unclear sort of what that mean and broad consent, what that means for big health data. So for example, there's health data that can be anonymized, but there is also de-identified data, which is data that has identifiers removed, but could potentially be traced back to the individual. And then in the US and overseas, data protection laws sort of are different in different states and across different borders. And there's also sort of accountability for the IRB as well as within the research team. And AI models are often what are called black box, meaning that it's hard to understand all of the different data sources, all of the different weights applied in the model. And so it might be hard for an IRB, which is charged with trying to understand the risks and vulnerabilities for participants in a research study, for example, to try to understand that with AI, right? Like they literally can't peek into that black box to understand where the vulnerabilities might be. And then just a few other considerations for IRBs or ethical review committees, another name for those, and this is taken from an article as well, that, there are, the weaknesses that already exist before healthcare AI, right? That there are inconsistent review criteria, for example, and, lack of transparency and a lot of projects to review, but there's also novel questions or novel challenges like the scope of big data, the new actors, as I mentioned previously, who might be conducting research about human subjects or using health data, and things like a lack of expertise in big data on IRBs. So let me just move quickly just to make sure I'm on time. So there's a few other health AI. We can think about health AI using concepts, using other ethics concepts outside of our core concepts in bioethics. Transparency, for example, is one. So how we could think about operationalizing this, or what this means, is that institutions that develop and use AI should be transparent with stakeholders, and that institutions that develop and use AI may have an obligation to make AI explainable or understandable. Trust is another concept, meaning that institutions that develop and use health AI should strive to be trustworthy or to be trusted institutions. And then responsibility and accountability. This is a term that's been used more often in thinking about AI specifically, that institutions that develop and use health AI should be held responsible and accountable for its limitations and for its harms. Okay, I'm going to actually just skip a few slides here. I did want to point out, so even though I mentioned that IRBs and ethical review committees, the sort of existing structures that we have to do ethics regulation, may be limited in how they can govern or even identify some of the ethical issues with healthcare AI. The World Health Organization did release a report about 2 years ago, outlining some of the ethical issues in artificial intelligence, specifically in healthcare, and did include a focus on some of the key bioethics principles, as well as principles like transparency and accountability and trustworthiness, for example. So that's this report says that some of the our existing core ethical principles that we use are important, but we do need to expand and think about things like transparency and responsibility. So I want to just briefly, and I don't want to take up too much time because I know we have about less than 10 minutes left. So I just want to just quickly talk about within this space what I focus on. So the ethical questions in healthcare AI that I really think about are equity and justice, right? So how do we think about how health AI might be contributing to inequities, and how can we think about healthcare AI facilitating health equity, and how can we think about injustices and ways to fix the system to sort of offer equal access to tools and opportunities within the healthcare AI space. And I'm going to zoom through this. So an article that I wrote a couple of years ago was just outlining that, raising the alarm that AI can entrench health disparities. And one of the things that we can do to address that is to prioritize health equity in AI and medicine, and address these examples of algorithmic bias that we're seeing. This is an excerpt from an article I wrote with a few computer science colleagues a few years ago, which is the focus of this article was how we can use that principle of justice and apply it to health AI model development. So thinking about how justice is relevant throughout the entire pipeline of developing a healthcare AI, from the problem selection, so what problem you think you want your healthcare AI to address, all the way to the data collection, to how you think about post-deployment considerations, right? So that's another approach that I've employed in my work, is to think about not just the principles, but to think about the principles and how they can be applied across the pipeline of AI development. And then I've also done some work looking at specific cases where I see health inequities and health justice issues as they relate to healthcare AI. So this is an article that I published with a few colleagues a few months ago, where we examined opioid risk scoring AI models that, again, use data points that we believe, just like the example that I shared with the health insurance, where that variable of healthcare expenditure actually resulted in bias. We analyzed opioid risk score modeling and identified some data inputs that could lead to bias for certain populations and could exacerbate health inequities. So, for example, opioid risk scores, again, the intention is good. The intention is to use data to try to predict who might be vulnerable or in danger of substance abuse, right? But some of the input variables, like criminal history and things like that, we identified that could lead to bias for some groups. And then let me, I think I will just quickly go over this. So again, in addition to IRBs not being the only solution, there's a need for sort of health AI at the governance of health AI across different levels, from institutional to state and federal to non-governmental organizations. And in particular, I wanted to highlight this article here, that there's also, my talk today has focused primarily on the US, but aside from the WHO article, the WHO publication, there isn't a sort of global approach to the ethical evaluation of healthcare machine learning. And this article that came out last year was really calling for that. And we still don't have that global system yet. So actually, yeah, let me just go back, sorry, I just want to very, very quickly talk about some research that I did focused on the FDA and how they are trying to regulate the use of healthcare AI. And I brought this health equity focus into, what I believe and doing some research on is that healthcare AI should be subject to a health equity review, again, through the pipeline of its development. So starting with a health disparity scan to look at the data, to look at if there are health disparities in the condition of interest that matter, to look at the data that's used to train the tool, to see what are the histories of that data, to do an equity-informed review of the model's decisions and performance testing, and then a sort of health equity review once the AI has been developed and used, to continually review it and evaluate it to see how it might be performing differently across groups. So with that, I will end. Thank you. And I think we do still have some time for questions. Sorry, I went a little bit over.
No worries. It was quite a whirlwind. You covered a ton of ground. So thanks so much. That was really terrific. We do have a few questions coming up, and I also see someone's got a hand raised. So we only have a few minutes. So let me just scan those very quickly. to see if there's something on research ethics specifically. This is an interesting, slightly different than what you approached. You said, can healthcare AI be able to help differentiate between an ethical and an unethical practice or incidents in health research? So taking a slightly different approach from the research that's being conducted, are there productive uses if you know, we're training a cadre of people who are interested in doing research ethics, and in addition to, you know, worrying about how it's employed in health research, could it be used in some ways to actually improve the process or help do that work?
Yeah, so there is on one of the slides I showed that, you know, that is one of the domains of application, that AI is being used in pharmaceutical research, for example, to sort of discover new compounds and things like that, and also in clinical trials to identify like patient cohorts, like the right set of patients for a research project. And so I think AI could be used for research ethics. So for example, a colleague of mine, so consent forms, right? We talked about consent forms. They're great, they're necessary, but they're often, for research studies, they're often tough to read. And sometimes we're not sure as investigators if our research participants really understand. And so a colleague of mine in California is looking at, can we use ChatGPT to summarize consent forms and present them in a straightforward, streamlined way, right? So for example, can you use ChatGPT to get better consent forms? Another potential application that's sort of focused on research ethics is maybe you want to, again, in terms of like problem selection, you could think about, well, where are there understudied research problems? Could you look at past data on past data from other studies where maybe there were findings that they couldn't follow up on or collect more data on? You could perhaps use an AI to identify understudied issues, or there are sort of small populations and rare diseases that are often understudied. That could be a way you could employ AI to identify some of those understudied areas or understudied populations with an ethical rationale to say, you know, it is important to conduct research for particular groups, for understudied groups, for example. So yeah, it's interesting. I hadn't really thought about it until right now, but I can imagine with some more time, I can imagine some ways that AI could be used to advance ethical biomedical research. Yeah.
That's awesome. So now all of a sudden the questions are coming in. Unfortunately, we are pretty much at time. But what we'll do is share with you the chat and the questions and answers. And I noticed that Tracy Orwig has a hand raised. And again, we didn't get a chance to see what that's about. But if you want to send those, it's okay. You've whet everybody's appetite, and it's great. The conversation started. So it's terrific that we got people thinking about it and raised some real issues for consideration, which is fantastic. To all the folks, if you can, we can try to follow up with you. If you can send them by email to the Moray email address, we can do a follow-up that way so that we can get you some follow-up. It won't go on forever. Kadija can't be your personal consultant for every AI issue you encounter. But hopefully she'll be willing to answer just a few short questions. Just a reminder, there is a quick survey that's going to come up at the end of this time, and just please join me in thanking very much Professor Ferryman for what a great session. Thanks so much.
Thanks so much, Ross.
Thank you.